So thank you for inviting me to discuss about this very interesting and important topic, fertility and radiotherapy. So let's start. So this is my disclosure. So as I have seen in my practice as a rad-onc, the issue of whether radiation therapy affects fertility was not much of a concern since most of our patients are elderly and therefore they are beyond their reproductive years. However, the issue of these issues of increasing cancer incidence in the young, as seen in this graph, as well as the increasing number of survival for pediatric and young adult cancer patients, have raised this issue the um, about the fertility and cancer. So in this era of modern radiation technology, as well as improved fertility preservation, it is critical that we evaluate and get a clear picture of the potential long-term side effects of radiation therapy on fertility. And so it is the objective of this lecture to discuss how radiation therapy affect fertility in both males and females, to discuss how we can reliably predict ovarian failure after radiation therapy, to aid in counseling our patients for possible fertility preservation methods, and lastly, to enumerate the more common clinical conditions wherein radiation can possibly affect fertility, as well as provide some actual patient cases. So first, let us discuss how radiation therapy can induce infertility, and there are three ways. So first, RT can disrupt the hypothalamic pituitary axis. It can also cause direct gonadal failure. And lastly, it can cause uterine dysfunction in females. So I will run through these mechanisms briefly, but the focus of this lecture will be more on how radiation can induce direct gonadal failure in males and females. So first, radiation can disrupt the hypothalamic pituitary axis gonadal axis. And this is a well-known established complication whenever we give cranial irradiation. So radiation-induced damage is possible in the hypothalamus, in the pituitary gland, or both. And this can lead to hormonal disruption, which can lead to the following side effects, such as gonadotropin deficiency, precocious puberty, and even direct or indirect ovarian or testicular failure. So second, we will go into details on how radiation therapy can cause direct gonadal failure. So in doing so, I think it's important to just run into some basics of gametogenesis, so we will better appreciate the effects of radiation to the testes and ovaries. So let's start in the testis. So in the male, spermatozoa arise from the germinal epithelium in the seminiferous tubules of the testis. So as we all know, production of sperm is continuous from puberty until death. So we will see this, how this impacts the effect of radiation sterility in males. So the post spermatogonial cells undergo through several stages of development. So from primary spermatocyte to secondary spermatocyte to spermatids, and then to finally to the mature sperm. So that's why there can be several populations present at one time, and these cells have varying sensitivities to radiation. So for example, the mature sperm and the spermatids are found to be more resistant to radiation as compared with the more sensitive spermatogonia. So that is why the effect of radiation on fertility in males may not be apparent immediately. So meaning there can be a latent phase, because after exposure to radiation, the person may remain fertile as long as mature sperm cells are present. So temporary sterility follows if all the sperms are used up. So since the sperm cells are continuously being produced throughout life, so the period of sterility may be temporary and last until the spermatogonia are able to repopulate again by cell division. So there can be also a recovery phase in the males. So as a result of radiation therapy, there is loss of proliferation of the Leydig and the Sertoli cells. And as the testis is considered to be one of the most radiosensitive tissues in the body, wherein doses as little as 0.15 gray can already cause oligospermia or diminished sperm. And doses about 0.5 gray can result already in azoospermia, while single dose of 6 gray can already result in permanent infertility. So now let's discuss the gonadal, how radiation affects the ovaries. So gonadal kinetics in females is opposite to those in males. So wherein the germ cells in the females are non-proliferative in nature. So meaning there's already a fixed pool of primordial follicles present at birth. So all the cells in the oogonial stages progress to the oocyte stage. And by 3 days after birth, all the oocytes are in their resting phase already, and there is no more cell division. So consequently, in the adult, there are no more stem cells present in the ovary, but there may be different types of follicles present, such as primordial follicles, primary, secondary, etc., which again have varying sensitivities to radiation. So for example, primordial follicles are thought to be more radio-resistant than the maturing follicles. That's why in females, there's a marked age dependence in radiosensitivity. So for example, it takes about 12 gray to induce permanent sterility in the prepubertal age, as compared to 2 gray to induce permanent sterility in the premenopausal age group. So ionizing radiation can cause direct damage to the ovarian follicles themselves. So particularly, it targets the granulosa cells that line and support the oocytes. So within a few hours of radiation, before any changes in the oocytes are detectable, cell death can already be seen in the granulosa cells. And with sufficient loss of these supporting cells, the oocytes loses its viability, leading to follicular atrophy. So therefore, RT or radiation therapy can hasten the natural decline of follicle numbers, leading to impaired hormone production. So, and unlike in males, there is pronounced hormonal changes that accompany radiation-induced sterilization in females. So overall, radiation sterility is very different between men and women, and the differences are summarized here. So in the male, there is a self-renewal system, while in the female, there's a fixed pool of primordial follicles already present at birth. So because of this self-renewal system in the male, there is a latent period as well as a recovery phase, which is not present in females. Also, as mentioned, induction of sterility does not cause significant changes in male hormonal balance, while in the females, sterility produces hormonal changes like that seen in menopause. However, both testes and the ovary, they're very radiosensitive organs, so wherein very little doses of radiation can already induce permanent sterility. So since the females appear to be more vulnerable to the effects of radiation therapy, an understanding of the dynamics of ovarian follicle decline will facilitate our ability to predict the impact of treatment on ovarian function. So in this way, we can counsel our patients appropriately with regard to their reproductive lifespan and their window of opportunity for fertility. So, as we all know, at any given age, the size of the follicle pool can be estimated based upon a mathematical model of decline. So here, the Fadi-Gostin model shows the natural decline in follicle numbers from birth to menopause. So according to this, the population of follicles at birth is about 700,000, and it undergoes a steady exponential decline until about 38 years of age, wherein the decline is accelerated until it reaches a population of about 1,000 at menopause. So Wallace and colleagues, who made important contributions in predicting onset of ovarian failure after radiation therapy, used this model, the Fadi-Gostin model, to report on their calculation on how radiosensitive the human oocyte is in terms of the LD50. So the LD50 is defined as the dose of radiation required to destroy 50% of the primordial follicles, and which they found to be at 2 gray only. So they were able to solve this based on observing 2 cohorts of women who had ovarian failure secondary to their radiation treatments. So furthermore, the authors sought to predict the age at which ovarian failure is likely to occur after radiation by accounting for age at treatment and the radiation dose that is given. So they defined ovarian failure as failure to undergo complete pubertal development or the onset of premature menopause before the age of 40. So this is an example of the method they did for a 12-year-old girl who received a dose of 10 gray to the ovaries. So using the Fadi-Gostin model, they were able to estimate the number of remaining follicles after a known dose of radiation. So for this patient who received 10 gray dose to the ovaries, they predicted that she will probably hit menopause at the age of about 19 or so, instead of the usual age of 50 plus years. So below, they also included different confidence intervals for their prediction. So this table displays the predicted age of ovarian failure with 95% confidence limits for patients from birth to 30 years at the time of treatment, and for ovarian doses of 3, 6, 9, and 12 gray. So for example, we have a 28-year-old patient, and she received about 12 gray dose to the ovary, then it is highly likely that she will experience menopause by the age of 32. So this is very important. So clinical application of this model will give us the ability to counsel the patients regarding their predicted window of fertility after radiation treatment. So Wallace additionally included in their calculations the effective sterilizing dose and the mean sterilizing dose. So the effective sterilizing dose, or ESD, is the dose after which the primordial follicles will decrease below 1,000. So effectively taking the patient's reproductive age to 58 years old in 97.5% of female population. While the MST is the dose that will induce immediate ovarian failure in 50% of the female population. So this figure shows the graphic representation of the ESD and the MSD. Okay. While these authors extrapolated the data from that previous model and they graphically depicted the risk of having acute ovarian failure or failure within 5 years of diagnosis, stratified by age and the dose received by the ovary. So for example, the estimated ESD for ovarian radiation at 10 years old is about 18 gray. For 20 years old, it's about 16 gray, and for 30-year-old, it's about 14 gray. So again, clinical application of this model would allow us to counsel women on their reproductive potential after radiation therapy. So lastly, radiation to the pelvis may cause uterine dysfunction that appears to put women at risk for pregnancy-related complications. So these findings have been attributed to reduced uterine volume, impaired uterine distensibility, uterine vasculature damage, and endometrial injury. So the degree of uterine damage depends on the total dose of radiation, the site, and also the patient's age at treatment. So studies suggest that the prepubertal uterus is more vulnerable to radiation than the adult uterus, with doses of about 14 to 30 gray already likely to cause uterine dysfunction. So this table shows the common adverse obstetrical and neonatal outcomes associated with radiation therapy to the pelvis, so including spontaneous abortion, preterm labor, low birth weight, placental abnormalities, etc. So the next two slides will show the most common clinical conditions describing infertility for males and females. So these are some of the patients that may probably benefit from a referral to a fertility specialist should they decide to have a child in the future. So for the males, we have direct testis irradiation for cases like seminoma or leukemia with testicular relapse, and also testicular cancer with high degree, since the testis is a target, so there's a high degree of exposure leading to permanent infertility. Actually, since the testis is very radiosensitive, even when the testis is not the target per se, for example, if it's a rectal cancer and the testis is just receiving what we call the scatter radiation, wherein there is moderate degree of exposure, temporary or permanent infertility may still occur. So for patients undergoing cranial irradiation for the following indications, for example, for pituitary gland tumor, for leukemia that needs prophylactic cranial irradiation, and for CNS tumors that needs craniospinal irradiation, there's also a high possibility that hypothalamic pituitary dysfunction might occur. So for the females, as you can see, pelvic irradiation may be given for a number of diagnoses. And the most common indication is for gynecologic cancers like cervical and endometrial cancers. So like the testis, since the ovary is also very sensitive to radiation, so almost all may lead to permanent infertility. So And also, like in males, for patients undergoing cranial irradiation, there's also a high possibility that hypothalamic pituitary dysfunction might occur. So here are examples of radiation therapy fields that may affect fertility. So first is an example of a rectal cancer case. So the radiation field is in the pelvis, but the testis was also delineated to check for scatter doses. So next is a cervical cancer targeting the whole pelvis where the ovaries lie inside. So most definitely the ovaries are included in the high dose region. And here are examples of craniospinal irradiation and total body irradiation, usually indicated in children and young adults. So although the doses given is not so high, since the gonads are very radiosensitive, fertility issues should still be discussed with these patients. Okay, so now I would just like to discuss briefly two actual cases that we had in our department. So first is a case of IFM, a 31-year-old female, single, newly gravid, diagnosed with squamous cell carcinoma of the cervix stage 3B. So the plan of treatment then was to give weekly chemotherapy with cisplatin plus complete pelvic radiation therapy with external beam and brachytherapy. So these are not my patients, but apparently, before the start of treatment, the patient was offered oocyte cryopreservation, but she was told that it may delay the cancer treatment. So the patient opted to forego the procedure and just to proceed with the cancer treatment right away. So she completed the planned concurrent chemoradiation therapy. So this is the actual RT plan of the patient. So this color wash represents the area which received the prescribed dose of 50 gray in 25 fractions. Then it was followed by 4 sessions of brachytherapy. So as you can see, the whole pelvis was included. So definitely the ovaries also received the prescribed dose of 50 gray. And if we're going to apply what we discussed earlier, the effective sterilizing dose for the ovaries for 30-year-old, it's about only 14 gray. So most likely this patient may not be able to bear a child in the future, and most likely she will reach menopause earlier than usual. So next case, this is a case of KTH, a 40-year-old male, single, diagnosed with seminoma, left testicle, status post left orchiectomy, status post 4 cycles of chemotherapy with metastatic disease to the abdominopelvic nodes. He was then referred for radiation therapy, and the plan was to give 40 gray in 20 sessions to the involved abdominopelvic nodes. So according to his attending physician, before chemotherapy, the patient was offered to have fertility consult, but for some reason during that time, he refused. And then when he was referred to our department, he was then again offered fertility consult, for which he underwent sperm analysis, which unfortunately showed already azoospermia. So the patient just decided to forego the fertility preservation options and just proceed with the cancer treatment right away. So also I would like to point out here this is the radiation field of the patient. So 40 gray is prescribed to the enlarged abdominopelvic nodes. But if we look at the scatter doses here in the right, so this is just the 0.3 gray color wash. As you can see, the testis is included. And as we discussed earlier, doses as low as 0.15 gray may already cause oligospermia. So we have to be very careful. Okay, so these are just some of the patients that we had who unfortunately had unsuccessful attempts at fertility preservation. So hopefully in the next lecture of Dr. Novero, he will give us more insights for these patients. Thank you.